was okay. Just any constructive criticism or compliments would be appreciated as well. So without further ado, the topic tonight is just a general overview of obstructive sleep apnea. I think many, or if not most, of the participants tonight have already been diagnosed with this condition and are on treatment for it. And you probably have lots of questions concerning treatment and maybe finer points. And it definitely is our intent as we go forward with these webinars to delve deeply into those issues as well. But because this is the first webinar that we are hosting, just wanted to give all those interested a general overview from the medical standpoint about sleep apnea. So what I'd like to talk about tonight is, first of all, just a brief discussion about why do we sleep, and then we'll delve into what is sleep apnea, what are the common signs and symptoms of sleep apnea, what are risk factors for sleep apnea, and then discuss what the health and safety effects are of untreated sleep apnea, and briefly diagnosis and treatment of this condition. So why do we sleep? Is sleep really a luxury? Is it something that one is stronger and braver if they can get by with less sleep? Or is it a mandatory physiological function? And I think we all know the answer to that. It is a mandatory physiological function. In animal models where animals are deprived of sleep, they literally die. And why does that happen? Well, sleep has many functions. One of the main functions of sleep is it's the mechanism whereby the brain can regenerate energy. But sleep is also critical for normal release and function of hormones in our body. Adequate sleep helps improve and create memories, and also solidifies learning new tasks and facts. It improves decision making and the ability to stay vigilant, the ability to stay awake. And there are other reasons as well. So when we look at the function of sleep as restoring energy to the brain, interestingly, our brains are only about 2% of our body weight, but yet our brains utilize 20% of our energy. 20% of the calories that we require to function is used by this small organ in our head. 2/3 of the brain energy is used for normal brain function, and 1/3 of the brain energy is used to remove toxins that build up over time while we're awake. So in general, when we are awake, the longer we're awake, the more we deplete our brain of energy and the more toxins build up in our brain. Sleep reverses that. Sleep regenerates energy in the brain, and it also allows for the removal of toxins that have accumulated in the brain. Sleep is important for normal hormonal release and function. Growth hormone, which is produced by a part of the brain, in children it promotes growth, but in adults it also is critical for healthy tissues and also for maintenance and building muscles. When we sleep, 75% of the total amount of growth hormone that's released during a 24-hour period is released within the first 2 hours of sleep. More specifically, it's released during deep sleep, slow wave sleep. Sleep also affects other hormones, and of interest, sleep or lack thereof affects hormones that control our appetite. There's a hormone that is released by the fat cells of our body called leptin, and what it does is it decreases hunger. If you have lots of stored energy in the form of fat, then you have lots of circulating leptin, which tends to decrease your appetite. But what also increases leptin is sleep. Ghrelin is a hormone which is produced by the stomach, and ghrelin has the opposite effect on appetite. Ghrelin increases hunger. And if people go for prolonged periods with inadequate or poor quality sleep, hunger tends to increase. And I remember I experienced this. I think most of you experience this. If you think about it, when you are relatively sleep deprived, you tend to eat more. That's a function of decreased leptin levels and increased ghrelin levels. So good quality, adequate amounts of sleep actually contributes to decreasing hunger and over time, possibly even decreasing weight. So sleep is very important. It's critical for our ability to create memories, retain memories, learn things, and stay awake. Deep sleep, which usually occurs in the first, most of it in adults occurs during the first couple of hours of our sleep period, is important for retaining facts and information without emotional context. Dream sleep, rapid eye movement sleep, which occurs later during the sleep cycle in longer and longer periods, is important for learning new procedures, how to do something, how to ride a bike, how to manipulate something. It's also important in retaining memories connected to emotional events. So bottom line is that sleep improves the brain's ability to learn through new and or strengthening networks of brain cells. That's what the background of this slide is. They're brain cells, and our brains are really a collection of trillions of these neurons, of these nerve cells that communicate with each other. And we form memories and we learn new things by new connections between these brain cells being created and then being supported by adequate sleep. So what about truck drivers? Drowsiness is a special problem because of the nature of what you do. It's routine, it involves highly overlearned tasks with minimal novelty. Once you learn and acquire enough experience in driving, it becomes a very routine process. As you know, you're usually in a sitting position. And when driving at night, by nature of the fact it's at night, you're in dim light or in near darkness. And dim light and darkness stimulates a hormone in our body called melatonin, which promotes sleep. So I'm going to show this video, and for those of you that can see the video, I'll let you watch it, and I'll caution you it could be disturbing. For those of you who are just calling in on the phone, I'll describe the video in a second. So I will show that video again. What this video is, it's a drive cam video, and on the left side, the camera's facing in, looking at the driver, and you can actually see the driver experiencing what are called micro sleeps, where he literally is dozing off. And on the right is the camera facing out towards the front, and basically he's approaching a stalled truck in the right lane, and at the last moment, thank goodness, he wakes up and is able to swerve and avoid collision. What's really scary about these events is that they can occur suddenly. And oftentimes you don't even have a recollection that it happened. But I think most of us who have driven any distances have experienced this phenomenon where we realize we're someplace and yet we don't really remember how we got there. And some of that may indeed be related to these episodes of microsleeps. So how much sleep is enough? Well, a recent study by the National Sleep Foundation looked at this and compiled a lot of data. And the bottom line is for adults between the ages of 26 and 64, it's recommended that you get a minimum of 7 hours of good sleep to 9 hours of sleep. Now, some people truly are able to function at a high level over long periods of time with as little as 6 hours of sleep, and some people require as much as 10 hours of sleep to do that. But if you are someone who routinely is getting less than 6 hours of sleep, that is not enough. That is not enough. And over time, you will experience problems related to inadequate sleep. And I think it's important, since we are going to be talking about sleep apnea from here on out, that it isn't just the quantity of sleep, but it's the quality of sleep. So if you have a sleep condition such as untreated sleep apnea, the quality of sleep that you're getting is also impaired. So what is sleep apnea? It's really a respiratory condition more than a sleep condition. It's a sleep condition only because sleep is disrupted, but it's a respiratory condition because what happens is that when people fall asleep with this condition, the back of their throat either totally obstructs or it incompletely obstructs. And when it totally obstructs, there's an absence of airflow, and that's called an apnea, which is Greek for no breath. Or if it narrows but doesn't completely obstruct, that's called a hypopnea, which is small breath. Now, these pauses in breathing can occur as often as infrequently as every 12 minutes an hour, or as often as every 30 seconds or more. And often they're followed by gasping and snoring sounds. So this is just a little graphic of what I was talking about. This is a side view of the upper airway, and in a normal unobstructed airway, you can see the blue is the flow of air from the nose and mouth down the back of the throat, behind the tongue, into the windpipe, the trachea. A hypopnea and or snoring occurs when there's partial obstruction of that airway, and that results in the soft tissues in the back of the throat vibrating, and that's what a snore is. It's vibration of the tissues due to turbulent airflow. When the airway is completely blocked, that's an apnea. So this next slide is, this next video is a video of someone with sleep apnea, and I'm gonna talk through it and explain what's happening here. So you can hear the patient snoring. He's asleep, and now everything is quiet. But for those of you who can look at the video, look at his chest and abdomen. You see how it's rocking? You see how it's moving? He's trying to breathe, but he's quiet because his throat is totally closed off and no air is going into his lungs. Then his brain wakes up. He has an arousal. His airways open up. You hear that snoring sound, and now the whole cycle repeats again. So the apnea, you're witnessing an apnea right here. And notice that he's trying to take a breath and isn't able to for a while until he finally has an arousal. His airway opens up and you hear the snoring sound. He won't remember any of this. There's no memory of this occurring. But it's easy to see by watching this video how poor quality sleep this is. And all this guy knows is that he's tired during the day, or maybe he has a headache in the morning, but he doesn't remember all of these events. Now, what's happening here, the video's still running, what's happening during these periods where his throat closes off and he's not getting air into his lungs, he's not getting oxygen into his blood. So his blood oxygen level is dropping. And the body starts responding to these attempts to breathe against the closed airway and the blocked and the low oxygen, and it increases the blood pressure, it increases the heart rate, and eventually it results in these brief awakenings, what we call arousals. And this can cycle throughout the night. So what are the signs and symptoms of sleep apnea? Well, these aren't your signs and symptoms. These are your bed partners. This is what your bed partner or your hunting buddy might witness. Loud snoring, gasping breaths, pauses in breathing, restlessness, restless sleep. And then the bed partner is the one often who first complains of poor quality sleep and even insomnia, because they're the ones that are sleeping next to this person with untreated sleep apnea, and their sleep, the bed partner's sleep, is being interrupted and affected. And leg movements are also frequently experienced by the bed partner of the person afflicted with sleep apnea. What signs and symptoms might the person with untreated sleep apnea have? Well, they may have morning headache. They may just have a general feeling of non-refreshing sleep. They may have a dry throat, general fatigue, sleepiness, maybe just trouble focusing or learning. Some other infrequently recognized but very common symptoms of untreated sleep apnea is frequent nighttime urination, getting up to bed to urinate more than once a night, especially in a younger person. That's not a prostate problem. It may indeed be untreated sleep apnea. Mood changes, irritability, decreased sexual desire, and weight gain. And you now know why perhaps the weight gain occurs from the previous slide I showed you with the hormones. I think it's also important to point out that many people do not recognize any of these symptoms in them, even if they exist. And the reason for that is twofold. One is that sleep apnea is a long-standing medical condition. It doesn't just appear. If it just appeared, then it would be easy to pick up the changes. But if it's something that develops over years and decades, then one gets used to whatever the slowly developing signs and symptoms are. That's common with any chronic, long-standing medical condition. The other reason is that people do what I call compensatory behaviors. They may drink a lot of coffee. They may drink a lot of Coca-Cola. They may smoke and not realize that what they're doing is trying to counteract these symptoms. What are risk factors for sleep apnea? Well, being male is a major risk factor. Increasing obesity is a major risk factor. Increasing age is a risk factor. Now, that doesn't mean that every male or every person who's overweight or every person who's over 60 has sleep apnea. I mean, we see everything, and we see people who on paper and even by exam look like they have it and they test negative. But common risk factors, the most common risk factors are male gender, increasing weight, increasing age. In females, it's interesting. Females are often protected from developing sleep apnea until after menopause. And it's thought that estrogen, the female hormone, which is present until menopause, protects, actually stiffens the upper airways. And I have seen many young, very obese females in pre-op evaluation for some sort of bariatric surgery like gastric stapling or something like that. And amazingly, very few of them actually have sleep apnea, and I think that's because of their age and their female status. But once women hit menopause, their risk for having sleep apnea greatly increases and approaches the same as if they were men with other risk factors. Other risk factors including crowding in the back of the throat, large neck circumference, and many of you know that the NFL actually has a sleep apnea screening program for their professional football players. It isn't just fat, but muscle in the neck can do that. Interestingly, it isn't just what's pushing on the upper airway, but it's also the shape of the upper airway as defined by the bony structures. And people with small jaws, recessed chins are at high risk for sleep apnea, regardless of their weight. And then sleep apnea is more common in certain ethnic groups, Asian, Hispanic, and African American. So I know everyone's muted, but does anyone know who this guy is on the left? I don't hear anyone. The guy on the left is King George III. He was the King of England at the time of the American Revolution. And the reason I show him is look at his profile. I would bet a lot of money that if this guy walked into my office and I tested him for sleep apnea, he would have it. And it's not because he's a little overweight, it's because of that jaw, that recessed chin. So that's just an important point. And then one simple exam that a lot of medical professionals do is just look in the back of your throat. And this is called the Mallampati score. And it's done just by having the patient open their mouth and not say ah, just open their mouth, and the examiner looks in the back of the throat. And on the far left, if that's what the back of your throat looks like, that's pretty low risk. Whereas on the far right, if you just open your mouth and you can't even see the back of the throat, or you can barely see the back of the throat around the tonsils, that's what we mean by crowding of the throat, and these people tend to have sleep apnea as well. So now I want to move into talking about the health and safety effects. And there have been many studies that have been done by consulting groups over the last 15 years, and they all are showing the same thing, that in the United States, untreated sleep apnea accounts for around $150 billion in excess costs. And these costs involve lost productivity, workplace accidents, but all I'm going to talk about tonight is motor vehicle accidents and other medical diseases. So these are facts, and this is why, regardless of whether or not there's a rule or you feel like you're being made to be treated for sleep apnea, you ought to seriously consider, for your own benefit, whether you're a commercial driver or not, why you should seriously consider treatment. Sleep apnea, untreated sleep apnea, is an independent risk factor for stroke. In fact, if you look at most people who have had a stroke, a large percentage, I mean like 80% or more of those people have sleep apnea. Sleep apnea is now recognized as a primary cause for high blood pressure. I mean, there are other things that cause high blood pressure, but sleep apnea by itself can cause high blood pressure. And what we have known even longer is in people with high blood pressure, especially people who have hard to control high blood pressure, who are on multiple medications, oftentimes untreated sleep apnea is making that high blood pressure more difficult to treat. Untreated sleep apnea increases the risk for both fatal and non-fatal cardiovascular events. So I'm talking about heart attack, sudden heart rhythm disturbance, i.e. sudden death. Interestingly and unfortunately, 20 to 25% of people with underlying heart disease, the initial presentation is sudden death. What I mean by sudden death is literally a heart rhythm disturbance that, unless someone is right there who knows CPR and can start basic CPR, these people die. There's also a greater prevalence of diabetes in people with increasing severity of sleep apnea. For example, somewhere between 58 to up to 85% of people with diabetes, and I'm talking adult onset type 2 diabetes, not juvenile diabetes, but the common diabetes that a lot of people get as they get older and as they gain weight, 58 to 85% of these folks have sleep apnea. I've already talked about high blood pressure. 50% of people with congestive heart failure have sleep apnea. So, and some of you may recognize that these some of these medical conditions, diabetes, adult onset diabetes, high blood pressure, heart disease, obesity, they're kind of sleep apnea, they kind of come together in this condition that you may have heard about, metabolic syndrome, because they are all linked. They all can make the other condition worse, but in particular, sleep apnea sits in the middle here and can, on its own, make high blood pressure worse, make diabetes worse, make obesity worse, make heart disease worse. So I don't want to bore you too much with medical stuff and graphs, but you know, as they say, a picture's worth 1,000 words. And this is looking at mortality in people with sleep apnea over time, over 10 years. And the people at the top here are people who do not have sleep apnea. And you can see that over 10 years, about 88% of them are still alive. In contrast, in people with worsening degrees of sleep apnea, as sleep apnea gets more and more severe, mortality increases over time. And in people with moderate and severe sleep apnea, their mortality is around 25% at 10 years. People with mild sleep apnea, it is significantly lower than those without it, but it's not quite as bad. It's around 20%. And for those, all of you who need to get your DOT medical recertification, some of the top medical reasons for a failed exam or for issuing a short card include these conditions that I've been talking about that are adversely affected by sleep apnea: heart disease, high blood pressure, heart failure, and type 2 diabetes. So what about the safety effects of sleep apnea? And for years, we've known that in non-commercial drivers with untreated sleep apnea, the risk of having an accident is around 2.5 times greater than matched controls without sleep apnea. But in 2016, we, along with Harvard and Virginia Tech and lead author Dr. Stephen Burks at the University of Minnesota, published a study looking at well over 1,000 drivers from Schneider National who were diagnosed with sleep apnea. And what this, and I just want you to know that my company, we had nothing to do with analyzing these results. All we did was provide the data, because all of these drivers were managed through our program on behalf of Schneider National. But any analysis of crash risk and stuff like that, it was done independently by Dr. Burks and his group at the University of Minnesota. And what it showed was that in commercial truck drivers with untreated sleep apnea, the risk of them having a preventable, i.e., driver at fault, DOT reportable, that is, significant crash, was 5 times greater than everyone else. And everyone else were groups of commercial drivers who were not at risk for sleep apnea and presumably did not have sleep apnea, a group of commercial truck drivers who were tested for sleep apnea and tested negative for it. They did not have it proven by sleep study. But also when compared to drivers who were diagnosed with sleep apnea and were compliant with CPAP treatment, there was no difference in groups of drivers who either did not have sleep apnea, were at low risk, and presumably did not have sleep apnea, or drivers who were being treated for diagnosed sleep apnea. There was no difference in their crash risk. But in drivers with known sleep apnea who were not adherent to CPAP therapy, their risk of having a significant DOT preventable accident was 5 times greater. And this was published, this was peer reviewed, so it had to go through rigorous review by outside medical reviewers. It was published in 2016 in the journal Sleep, and some of you may remember it actually made national news. So how do we diagnose sleep apnea? Well, in our program, the primary means in which we diagnose people determined to be at risk for sleep apnea is through a home sleep test. And the method, as most of you know, that we use is the watch pat. And this is a picture of it here on the right. For those of you who have had this test done over the last year or two, you now know that we only have one probe. And in this one probe on the finger, all of the pertinent data is collected. And what is that data? That data, this is an interesting way to test for sleep apnea that's been validated more than any other portable device out there. Been validated against the, quote, gold standard in-lab polysomnogram. And what this finger probe is doing is it's measuring oxygen level in the blood. It's measuring how fast the heart is beating, but it's also measuring what's called the peripheral arterial tone, the tone of the tiny little blood vessels in the finger. And what they have discovered is that when there's a respiratory event, these three parameters, the tone of the blood vessel, how tightly it's constricted changes, how fast the heart beats, and obviously the drop in blood oxygen level occurs. And putting that together is how this device works in being very accurate in diagnosing sleep apnea if it exists. So treatment of sleep apnea. So this is just a quick little cartoon that shows, this is what I showed you earlier. This is a normal breathing. This is when the tongue falls down the back of the throat, the airway's obstructed. So how does CPAP work? Well, it's positive airway pressure. That continuous flow of air from the machine keeps the airway open. It works as a stent that keeps the soft tissues, the back of the tongue, from obstructing the upper airway. And that's how CPAP works. So what about CPAP? It is the most effective treatment for sleep apnea for all severities of sleep apnea. It is by far the most studied treatment for sleep apnea, and it is the only method of treatment where long-term effects of treating sleep apnea have been documented, as far as the effect of sleep apnea on blood pressure, the effect of sleep apnea on diabetes, effect of sleep apnea on risk of heart attack, effect of sleep apnea on risk of atrial fibrillation, the effect of sleep apnea, well, this isn't pertinent to you guys, but in people with heart failure. CPAP is very, very low risk. That's not to say that there aren't side effects, which are generally manageable with good follow-up care, which I hope we have provided and continue to provide to all of y'all. But as a treatment, as a medical treatment, it is very effective and very, very low risk. But there are other treatments, and you've probably heard more and more about the, quote, oral appliance. These are more better described as mandibular advancement devices. These are devices that have to be fabricated with the help of dentists. And what they do is basically pull the lower jaw forward. And what that does is, in most people, it also opens up the back of the throat. And a lot of people find this to be effective, and there are plenty of people who find it to be preferable to CPAP. The problem in our world with these devices is that it requires a dental evaluation and fabrication, and that in and of itself creates problems. There are no national networks like we have developed for dispensing treatment. It takes time to fabricate these devices, and they're not cheap, and it requires follow-up visits with the dentist. It also requires follow-up sleep testing to confirm that it really is working, and it also, there's a period of time to acclimate, because these devices, initially they're not comfortable, and it takes time to gradually increase the amount of protrusion of the lower jaw until you finally reach a point where it is effective. And what do you do in the meantime as far as treating a driver who's been diagnosed with sleep apnea? And you want to stay in service, and your employer wants you to stay in service. So what do you do in the meantime? There is newer technology that can track compliance, but it's still difficult, and it's limited compared to how we can track compliance with these CPAP machines. And then surgery. I need to tell you, the most important message I have with surgery is that it is generally not a cure for sleep apnea. It isn't. What it does do in most cases is it facilitates acclimation and adherence to CPAP. It has side effects. I mean, it is surgery, and some of these side effects are serious, and depending on the type of surgery, and there's all different kinds of surgery, but you have to know that there's pain involved and bleeding, and there's even a small but definite risk of death with these surgeries. And beautiful example of surgery was this UPPP that was being done everywhere on everyone maybe 10 years ago. And we now know that in general, that procedure is not effective and actually creates more problems and side effects because of it. UPPP is uvulopalato-pharyngoplasty. This is where, I should have a slide on this, I apologize, but this is where the surgeon goes in and resects the uvula. That's that, when you open your mouth, there's that thing that hangs down. They cut that out, and they tighten the soft palate, the soft tissues in the back of your throat. They tighten it. That's what that procedure is. Now, what about weight loss? It is a fact that if someone can lose at least 10% of their body weight, they can improve their sleep apnea. Their apnea-hypopnea index will go down. And in some cases, I said in this slide, in mild cases, it sometimes cures. I will tell you that just yesterday, I saw a sleep study, an in-lab sleep study, on a driver who 13 months ago was diagnosed with severe sleep apnea. He had an apnea-hypopnea index, I think, of 65 events per hour. Forgot what his weight was, but I do know that over the last year, he has lost 110 pounds. And he went in-lab, and guess what? He's, quote, cured. He's cured. He does not have sleep apnea. He does not need to wear CPAP. So that's great. What's the problem with weight loss? Well, remember that slide where I showed y'all the risk factors? I listed male, I listed obesity, increasing weight, and I listed increasing age. And it is a fact that regardless of what your weight is, what your body mass index is, you age. And age is an independent risk factor for sleep apnea. We see drivers all the time who are male, who have very high BMIs, but who are very young. And many of those guys test negative for sleep apnea. But I guarantee you, if nothing else changes other than they age, they will eventually develop sleep apnea. So one big problem with weight loss is, assuming you can keep it off indefinitely, you still are going to age. So there's always the risk that over time it could reappear. But probably a bigger problem is after 2 years or less, almost everyone gains back what they have lost, unless they have had some sort of surgery, like bariatric surgery. And even a lot of those people over time start to gain weight for a variety of reasons. So weight loss is good for many reasons, many reasons that go beyond sleep apnea. And I encourage it. I think it's great. And if you're able to, if you've been diagnosed with sleep apnea and you've lost a significant amount of weight, or even 10% of your baseline weight, whatever it was, I think most of, if not all of the carriers that use us in their program would approve you to go back in for a sleep study to see if indeed your sleep apnea has resolved. So at this point, that's all that I have prepared. I would encourage y'all, I think people have started to type in some things. Okay, first
yes,
comment.
Dr. Berger, there is a question in there regarding can someone with a deviated septum or breathing through only one nostril be confused with sleep apnea?
Okay, that is a great question. That's a great question. I'm not sure what the questioner means, confused with sleep apnea. If the question is from a screening standpoint, can somebody misinterpret noisy breathing through the nose as snoring? I guess so. I guess so. But if that's all it is, if and when that person is tested for sleep apnea and they really don't have it, then they're not going to test positive for it. But I like the question for another reason. I'm not a surgeon. I'm not an ear, nose, and throat surgeon, but I have been told by ear, nose, and throat surgeons that probably the most effective surgery that they do is in people with sleep apnea who have a deviated septum or enlarged nasal turbinates or even nasal polyps, something that they can relatively easily open up in the nose. And oftentimes that can make the sleep apnea less severe and oftentimes make tolerance to CPAP much improved. And in mild cases of sleep apnea, it may indeed, quote, treat it. Why is that? Because most people, really all of us, we prefer to breathe through our nose at all times unless we're exercising vigorously, and certainly when we sleep. And if we're breathing through our nose, but the resistance to airflow is increased, then you have to suck harder. You have to create more negative pressure to get air in, and that negative pressure will tend to collapse the tissues in the back of your throat. So I think that in someone with suspected sleep apnea or with diagnosed sleep apnea, and if they do have a problem with bad deviated nasal septum, and in particular with nasal polyps or hypertrophied turbinates, sorry, it would be reasonable to have that looked into. And that kind of
Dr.
surgery.
Berger, there was a follow-up. There was a follow-up from a caller asking if the lack of oxygen intake can mimic apneic conditions as a result of that structural problem in the nose.
Let me do this. I think I can unmute that person, and he, if I can find him, and it's Kevin. Kevin, I'm going to unmute you, and why don't you explain your question to me? I think I can unmute him. Kevin, are you there? Or maybe, Kevin, you need to unmute yourself if you can. Well, I can't unmute him. I apologize. Can the lack of oxygen intake mimic apnea conditions? You mean with the nose? Is that what?
I'm thinking yes, Dr. Berger, as it was kind of a follow-up to his original question about the deviated septum.
Yeah,
Okay.
we get that question a lot from drivers.
Yeah, what I'm having trouble with is what they mean by lack of oxygen intake, or they mean the lack of the ability to get the air in because of sleep apnea, or?
I'm thinking because of the inability to get the oxygen in due to kind of a crowded nasal passage, can that mimic sleep apnea? In other words, does it act like sleep apnea and perhaps it isn't?
No.
Right.
Like I said before, people can snore. Snoring occurs really in the back of the throat. Okay, it's that turbulent airflow in the back of the throat, and people can snore with the cause being something higher up in the upper airway, like in the nose. For the reason that I said earlier, if airflow is restricted in the nose, then you have more resistance to getting the air in through your nose. And unless you open your mouth, you're going to suck air in. You're going to create more inspiratory pressure. We breathe. Let me tell you how we breathe. We breathe by expanding our chest. And when we expand our chest, that creates a negative pressure inside our chest relative to the atmosphere. So we suck air in. So breathing is active when we inspire, when we breathe in, by expanding our chest volume, creating negative pressure that sucks the air in. So if you have an obstruction in your nose to getting the air in, you're going to have to create even more negative inspiratory pressure. And when you do that, that puts the tissues in the back of your throat more at risk of collapsing. So if you can clean out, somehow alleviate the airflow resistance obstruction in the nose, then you're able to generate less negative inspiratory pressure, and therefore to get air in, and therefore the tissues in the back of your throat may be less prone to collapse. I hope that makes sense.
Right, and I think a good point was made by one of our attendees relative to, those individuals often become mouth breathers too, right? Because they don't have the nasal airflow.
Yes. Any other questions? Well, a lot of you may just be listening in on a phone or may not be able to type in questions. So like Katya said, feel free to email us the questions and we certainly can answer that. And also, for those of you that want to take the time, give us a little feedback just on the technical issues, like for those that were able to see the presentation, did it display correct? Did it display okay? Did the videos look okay? Run right? The audio, someone said earlier it sounded like there was a dog barking. I don't know what that was. May have been a dog. Not here though. So yeah, I enjoyed this. I hope y'all did. I don't think anyone that signed in has signed out, so that's a good sign. But I'm sure we'll hear more comments. Wendy, Wendy is on this presentation as well. Wendy Sullivan, some of you may know who she is. Wendy, are you still there?
I'm still here, Dr. B.
Yeah, Wendy is an RN, and she spent years, I won't say how many, but years actually working in hospitals and med psych and surgical units. Eventually she worked at Schneider National in their occupational health department. And I met Wendy back in 2003, and make a very long story short, we just started brainstorming how we could come up with a program that could be nationwide to address the problem of sleep apnea in long-haul commercial drivers nationwide. And a few years later, Wendy actually joined PSS, where she is today. And Wendy has a great background, not only in the matter at hand, but also just in DOT medical issues as well. So is there anything else you wanted to add or say, Wendy?
No, thank you for that, Dr. B. I think the plan is going to be that this presentation will end up on our website as well. Am I correct?
Yes, it is being recorded, and we will be posting it.
Wonderful.
And I just wanted to thank everybody again for taking the time to attend our very first webinar. We do plan to go ahead and start doing these on a quarterly basis. We have had some drivers email us with some topic interest to them. So going forward, we wanted sleep apnea just to be explained as the kickoff to our webinars. But going forward, we will these webinars will be a little more specific to the challenges that drivers face using CPAP. And we hope to have a more interactional webinar with them and some of our team also on the calls. So again, thank you so much. And please email me if you have any questions, suggestions. We're excited to hear your feedback, and have a great evening, everybody.
Thank you.
Thank you.